We are going to be talking, just to give you an update, on the clinical trials that they are active in the neuroendocrine unit. So what is it? The agenda for today will be like talking about what are clinical trials, especially the randomized control trials, which is mostly the studies that you have seen in the NET unit. In these trials, a lot of things are considered. We will go in detail later on. But one of the things that I consider is like there is a lot of ethics before running a clinical trial. And we will talk today more about ethics than we have done before, because I have some questions from people that why didn't give me the treatment I want? You know, that would be the most ethical thing, no? I need the treatment, just give that to me. Why have to be not knowing what I am having? You know, so it's a debate, and it's like a fine line, and we will go through slowly. And yeah, we will talk about the active studies in the NET unit, and also there is I didn't put it on the presentation, but in the magazine there is a lot of trials that they are coming. The reason I didn't put them on the presentation is because they are coming. There is still subject to change in the inclusion criteria or some eligibility or things like that. So I don't want to give you like false information. Okay, so what are randomized controlled trials? Randomized controlled trials are considered the gold standard in medical research in order to assess the effectiveness and the safety of a medication, of an intervention. So it would be really easy to say, okay, if I need a medication, just give them to me. But before, we need to assess if this medication is going to be effective. The only way we can eliminate bias is by making the study in a very controlled environment. And what does it mean? So for example, like patients are randomized. Randomized, it means that the allocation to the different interventions, it's done without the control of the experimenter, without the control of the doctor, and without the control of the patient. And that eliminates a lot of the bias that we carry, you know, like expectations about the treatment, like different ages might respond differently to the treatment. So by being allocated in a random way, then it would be more or less equal number of people in the different arms. You know, that the other key element of a clinical trial to make it unbiased, it's the blinding. You know, there are different types of blinding. Sometimes the blinding could be just the patient, so the patient doesn't know which treatment is being given. Some of the times it's not just in most cases to make it's double blind. So it's not just the patient, but also the doctor that is giving the treatment doesn't know which treatment the patient is having. And this is key, because it's in the 40s, like long time ago, when people were starting with the clinical trials. I read this, it was really funny, funny now. In one of the first cancer drug treatments, it was given to a patient without him knowing, and you know the doctor was like lying to the patient on the treatment that he was giving to the patient. You know, it was given like a medication that it was completely experimental. There wasn't any ethics behind it. He just thought that it would be beneficial for the patient, and it was given to the patient without him knowing that he was given a medication that it wasn't given to anyone else. So, you know, like today that would be something completely outrageous. You know. Although it sounds like a bit funny that at some point in time that was something that it happened, you know. So the clinical trials, they go through a very, 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 very strict controls, and yeah, we will go. Sorry, I'm jumping ahead. And then they also, in order to assess whether the medication is effective, let's say that the patient comes, is randomly allocated to one intervention or another. And then it has to go for a long time to assess those treatments. Also, it could be we need like a lot number of patients in the study in order to have enough power to assess the difference that we are looking for. So you see that it could be quite tedious. And I have to say that I was really pleased in Christo's presentation, because some of the studies that they were up and running when I was working here in the Rule Free, now the results are coming out now. So, you know, it's like a very laborious process that it could take like a good few years in order to assess whether if that treatment that was quite promising is in fact as promising as they say. So ethics is a very hot topic on this. Like in the 1950s, like they have to set up some standards on the ethics that we need to follow in order to perform clinical trials. And the Declaration of Helsinki is being updated many times, but it's like the main guidelines of ethical research. You can check that online, but the main focus of the guidelines is about like prioritizing the welfare of the patient over the scientific interest. And also the ethical principles, they tend to be paramount over the laws. So that's something that it has to be taken into account in order to conduct the clinical trial. Of course, but there is something that is like a fine line. It's like, from the individual point of view, the patient should be treated with the best available treatment, regardless of whether this treatment is experimental or if their efficacy is being proven. But then if we take into account that in order for the treatments to be available for everyone, we need to take into account not just the individual that needs the treatment, but what is the best way to assess this effectiveness of the treatment? And that is the randomized controlled trials. And in order to conduct a very well randomized controlled trial, we need to go through processes like the patient doesn't know which treatment he's having, the doctor doesn't know which patient is having, we don't know which intervention you're going to be allocated. So that doesn't sound very ethical, no? For one person, It's like, I am sick now, I want that treatment. I don't want to be for 1 year on placebo, having an injection that is just normal saline, So balancing both things is like key, like we need to balance how we can satisfy being ethically loyal with a patient that is in need of the treatment, but at the same time, taking into account the population that in the greater good, the best way to assess that treatment is by not being so loyal with the individual ethics. I don't know if I'm being clear with that. And it creates this kind of like a very fine line between the patient and the public, and the general population. So anyway, we can discuss this in more detail if you have any questions about, like where is the line or how that line is drawn. So let's talk about like the trials that they are active at the moment. One of them is called REMINET, and then it's a phase 2/3 randomized controlled trial. The phases is related of the stages. Phase 2 tends to be like a small number of patients, and then in phase 3 is already like a large scale, okay, like European studies and things like that. Then it's blinded, so if you enter into the study, then you will not know if you're having the treatment or you're having the placebo. And then the placebo, it tends to be either like no treatment if there is no evidence that any treatment is beneficial, or it could be the standard treatment at the time. That was what's happening with the people who was receiving this PRRT, that some people was having the injection because it was at the time the best available evidence for patients on that they were stable, and then you will not be able to give to those patients placebo, because once the evidence has been established, you cannot take it away. You cannot take away, like the best available treatment. Sorry, I'm getting a bit. Yeah, so in this particular one, the eligibility criteria would be patients that they are non-resectable. That means that maybe some lesions could be removed through surgery, but not all of them. And it's for duodenopancreatic neuroendocrine patients. And then it has to be after having the first line of treatment. For most patients would be either surveillance or like having the somatostatin analogs monthly injection. So if you've been having just that first line of treatment, then you might be eligible for this study. Another study is called IMMUNET, and this one is like it's quite experimental. There's been a lot of information about this in the media about boosting the immune system as a new way of treating cancer, and that also is coming through neuroendocrine tumors. So in this one, they want to analyze tissue And exactly, I mean, I haven't been able to check the protocol in detail, but they want to assess, like, from tissue, how we respond to different immunotherapies. So that's something that is still quite experimental. You know, I think like the only thing about this one is like, is for new patients that they haven't had any treatment whatsoever for any kind of neuroendocrine tumor, but it's likely that it's possible that you might need to have 2 different biopsies, because the one that was taken for research will not be used to diagnose the neuroendocrine tumor. That's also open to debate, you know? Like, why do I need to have 2 procedures if in the same one, you know, you're gonna take all the tissue that you need? And then the other one is the CLARINET FORTE. This is like, some of you might be on the monthly medication lanreotide autogel. 100, at the moment, the licensed maximum dose is 120 milligrams every 4 weeks. Some patients are receiving this medication, 120 milligrams, every 3 weeks. And now this study is assessing whether the symptoms and also the tumor control are better controlled by increasing the medication to 2 weekly. So this study at the beginning, because they are giving you quite a lot of the medication, then at the first 6 weeks of the study, you really need to be in the hospital for like in the first 6 weeks, you have to be 8 times in the rule-free, just to make sure that the increase in dose in the somatostatin analogs in the system is not created any kind of toxicity that need to be watched out. Once you've been on the medication, like 2 injections are in your system and you're coping with it well, then the home care service will give you the medication when you're at home. And it would be like one injection at home and the other one in the hospital. And that will make it like a monthly visit to the hospital instead of 2. And then patients for these studies, like for midgut and pancreatic, and then if you are a midgut neuroendocrine tumor, you will continue on this treatment for as long that is beneficial for you. So there is no toxicities, there is no progressive disease. And then for pancreatic, it's up to 2 years. And that's, you know, that's how it was at the protocol. I don't know exactly what was the reason not to make the pancreatic until they progress. But what we've seen for the clinical trials is like when someone receives a treatment that has been beneficial for the individual patient, then it's very easy to get this treatment outside the trial, you know, like as a compassionate use. You know, of course, it would be very difficult for GPs or any funding bodies to fund a medication that is not licensed for the treatment that we want to give you, even if there is a little bit of evidence for that. But normally the pharmaceutical companies, as a gesture for participating on the clinical trials, they tend to extend as compassionate treatment if the patient is having any benefit from the treatment. And these are, so far, the 3 new clinical trials that are coming in the NET unit. And that was like the presentation, like very short. Thank you so much. Okay, I'm gonna have to be like both things.
So when you are looking for patients for trials, is this something where an input from the patient is useful, or do you dredge through all of your records looking for, that person would be useful for this, or that person would be useful for that? So I guess the question is, do we come to you or do you come to us?
It's both. We don't sit down and scroll through medical notes to see how many patients can we recruit. It's actually the other way around. When we have patients that we think that would benefit from a treatment that is not available in the public but is within the clinical trial, then we tend to offer that to a patient that we think it would benefit from it. Okay. And then of course, because like the clinics tends to be very busy, sometimes talking about a potential clinical trial might be like something that for the future, but there is no time to discuss it now. So if a patient brings it up as that they are interested in that, then it's something that then we make a record for when that becomes available. Another one?
So do you discuss this in the MDT as well as the person's, forthcoming or ongoing treatment?
Yeah, well, I mean, I no longer work as a clinician here. You know, I work already, I moved career into statistics in clinical trials. But yeah, one of the outcomes of the MDT is the management. And the management includes any potential clinical trials that might benefit the patient. Okay. Any other questions? No.
How much are clinical trials dependent upon pharmaceutical companies on financing, or are there occasions when the hospital itself can finance these?
That's a very, very important question. All of these trials, they are part of the industry. So they are the pharmaceutical companies who are sponsoring. There is a medication that is going to be marketed or a medication that is already in place that they want to find a new application in order to keep on selling the medication. So of course, this is something that is a double thing. Of course, for patients who undergo a clinical trial, that could have a benefit for a new treatment, but of course that license a new door for the pharmaceutical industry to sell more of the medication. There is a lot of clinical trials that they are sponsored by the hospitals, but they are not normally about new medications or new treatments because there is no technology in order to develop these kind of new compounds. But they tend to be about, like, for example, like how to improve the services, like, for example, like interventions like different types of surgery, you know, things that are already up and running to find different ways to make it more efficient, you know. And for example, there is a case of a clinical trial that it was done through academia because there wasn't any pharmaceutical industry that wasn't gonna able to do it. And I hope I'm gonna get the facts right. There was a medication for, I think it's preeclampsia in pregnant women, that there were some clinical trials assessing new compounds to prevent preeclampsia in pregnancy, and nothing was working. And there was a trial with an unlicensed drug that it was already in the market for decades, that it was really cheap, and of course no pharmaceutical industry is going to use a medication from which they cannot make any profit from. And it was done through academia. And now that medication, which I think it was magnesium sulfate, has become the gold standard in the treatment of preeclampsia. I hope I got the facts right. Second.
Thank you. So are the clinical trials initiated by a pharmaceutical company, or now you're doing the statistics, and you therefore your statistics show that there are certain benefits, do you then have to go and find a pharmaceutical company that would finance that particular test?
It depends. It's true that a lot of the studies, they already come from the pharmaceutical companies from which the medication that is going to be tested is theirs. That's the most common practice. But it's true that there is like a there is a merging between academia and some pharmaceutical companies. So for example, like the whole new wave of genetics and proteomics, there is a lot of investigations that they are doing in academia, but a lot of the compounds or proteins that they discover, they have potentiality to become drugs. And then they are like common interests in order to combine forces, you know, like money-wise, a pharmaceutical company is able to spend like the large scale of money that it requires to do a large randomized controlled trial across Europe or the world, that no hospital would be able to fund such a study. And then, you know, like in biomedical science or in academia, we might be able to discover these applications that they are beyond marketing a new medication. Yeah.
Did I understand correctly that the lanreotide will be given every 2 weeks?
Yes.
And so does that reduce the symptoms of flushing so that possibly you wouldn't need booster injections?
That's the plan.
That's the plan.
Yes. So
Has that worked with the people in the trial?
it's still ongoing, and I don't know the preliminary results because they hasn't been out yet.
Oh, so when will you know?
Well, normally the studies, they don't release any data until the study is complete or when they are very close to complete.
Okay,
Don't forget that it's a blinded trial.
Okay.
So we don't know at the moment who is having who is having what.
Did you choose anyone who did booster injections as well?
I think you have to be on lanreotide 120, but I'm unclear of that specific exclusion, if it's, if you can have boosters or not. But you can discuss it. You know Melissa? Melissa is the senior.
I was interested in the results if the people who were on the trial did boosters as well, and then maybe they got off the boosters.
Yeah, at the moment there is no preliminary data. No.
You don't know. But soon.
It might be soon. It might take another year, but yeah.
Another year.
No. I'm just roughly.
You don't know.
Yeah, I don't know.
Looking at the descriptions of the various clinical trials, a lot of the stuff is written in jargon. It's written in medicalese, or it's written in scientificese, or whatever, or pharmacology, or whatever it is. How would I know which trial I would like to be part of if I don't understand what the stuff means?
Yeah, a lot of these trials, they are still not open to recruitment, and the information that is available is very sketchy. So the only reason that we wanted to put all of them in the magazine is just to make you aware that there is a lot of new trials coming. It's true that if you're unclear of some of the what they mean, of you are eligible or not, this information in here is not going to help you, because it's not comprehensive. It's just like a few touches of what they're looking for. But if you are interested in participating in one of the trials, you can discuss that with the senior research nurse in the NET unit, which is Melissa Pack. I think the telephone is here. Yeah. Which is on the magazine. And then she can walk you through your type of NET, what you want to achieve from the clinical trial, and if there is any clinical trial that would be of your benefit. Okay?
Thank you. That's great.
Any other questions? Okay, thank you so much.